Good afternoon, and welcome to this session on our webinar on coronary artery abnormalities. I'm Annette Baker. I'm the nurse practitioner in the coronary program at Boston Children's Hospital, and we're joined today with Dr. Newberger and Dr. Coronaries, who will introduce themselves.
I'm Jane Newberger. I'm an associate chair of the Department of Cardiology here, and also the medical co-director of the coronary artery program.
Hello, everyone. My name is, Luis Quinones. I'm a surgeon, cardiac surgeon here at Boston Children's Hospital. And again, I co-direct on the surgical side the coronary artery program with Dr. Newberger.
So we're very happy that you're all joining us, and we're going to start right off with just a description of what are coronary artery anomalies, and I'll let Dr. Newberger take it from here.
Well, we'll start with basics. The coronary arteries are tiny blood vessels that run on the surface of the heart and supply the heart muscle with oxygen. And you can think of them as the heart's kind of fuel lines. A coronary artery anomaly is a condition where your child is born, or you were born, with one of these arteries beginning or taking off in the wrong place, usually from the aorta, which is a main artery that leaves the heart to supply oxygen to the body. There are different types of coronary anomalies, but today we're going to talk about the most common type we see, which has a big name called anomalous aortic origin of a coronary artery, or AAOCA. When a coronary artery starts from the wrong spot, sometimes it has to travel back to its proper location by passing between the aorta, which goes out to the body, and the pulmonary artery, which also leaves the heart but goes to the lungs. If the artery is between those, it's called an interarterial course. And if it runs in the wall of the aorta, it's said to have an intramural course. There are two types, left and right anomalous coronaries. The main concern is that when a child exercises very intensely, their heart pumps more blood through those vessels, and the aorta can swell or increase in size and have higher pressure. If a coronary is running in its wall, it can squeeze that coronary artery, kind of like pinching a garden hose. And that squeeze can temporarily cut off or reduce blood flow to the heart muscle, depriving it of oxygen. And that lack of oxygen can cause someone to have chest pain or rarely trigger a heart rhythm problem, which can lead to more serious problems. Of note, those problems, those serious events, are almost always during intense exercise or immediately, within an hour of very strenuous exercise.
So how do you usually detect a coronary artery anomaly?
We detect them either through symptoms or by chance. So children can have symptoms of angina, which is chest pain, pressure, or kind of a squeezing feeling caused by the heart not getting enough oxygen. Much more rarely, an individual with one of these coronary anomalies can faint or collapse from a heart rhythm problem, especially related to exercise. Most of the time, though, these anomalies are discovered completely by chance during a workup for some other problem, like a child might have an echocardiogram or a CT scan to evaluate something unrelated, and the doctor sees that anomaly.
And then what kind of tests do we do to see if the heart is actually suffering from ischemia with exercise, and to assess for the risk of a sudden event? And at what age, I guess, do we start doing these tests?
So we have two main goals with testing. So the first is to see the exact anatomy of the artery, and then the second is to check to see if it's causing a problem during exercise. And the tests that we choose to do depend on your child's specific situation. So for the tests that look at anatomy, we like to see a detailed kind of three-dimensional map of the coronary artery path. And we generally will do a CT scan which gives us beautiful high-resolution pictures. These show us exactly where the coronary runs and whether it's tunneling inside the wall of the aorta. A standard echocardiogram won't be enough to see that kind of critical detail. Some centers might do an MRI as an alternative. We then do tests to check for whether there are problems with stress or exercise. And these tests help us tell whether when you're running and when your heart is working hard, if the muscle is getting enough oxygen. The types of tests that we do include a stress echocardiogram, where we use an ultrasound to look at the heart and how it moves while your child exercises. Sometimes we do a nuclear test, which is similar, except you're using a special tracer or dye to create a kind of color-coded map of heart flow in the heart muscle. One can also use an MRI, usually with medicine to simulate exercise. PET scans are the most sensitive way, without doing a heart catheterization, to determine if there's problem with blood flow with exercise. And then finally, a heart catheterization or cardiac catheterization is the gold standard. And there, a cardiologist guides a very thin, flexible tube or wire into the heart and inside the coronary artery. And they use medication to simulate exercise to make the blood pressure high and the pulse rate high. And we can directly measure the pressure in the coronary and flow inside the artery to see if there's any blockage. Finally, if a child has actually collapsed during sports, we might not need to do extensive testing because the body's already shown us that this anomaly is dangerous. And so we would go forward generally to surgery. Sometimes we do a cardiac MRI just to see if there's been any silent damage to the heart muscle before the operation.
Okay, well, obviously we know that left and right anomalous coronaries have different risks. I think maybe we should talk first about anomalous left coronary with intramural course, and what are the recommendations if you have this anatomy?
So the left anomalous coronary is associated with a much higher risk of sudden death or sudden cardiac events, maybe 30 to 50 times greater than if you have an anomalous right. And for this reason, there is universal agreement in national guidelines, and our own team strongly recommends surgery to repair this artery in all patients with the anatomy, even if they have no symptoms or normal stress test results, as long as that coronary runs in the wall of the aorta.
And I know anomalous right coronaries are a little more difficult. And can you talk a little bit about anomalous coronaries and its impact on health?
Sure. So right anomalous coronaries represent a much more complex situation. They are much more common than left anomalous coronaries. They happen in about 3 out of every 1,000 people. But sudden cardiac events are much, much rarer. And while the absolute risk for any individual child is very low, studies of competitive athletes show that their risk of having a sudden cardiac event is significantly higher than that in the general population. That's why we take this condition seriously, especially in active teens, children, and even young adults. And we evaluate the situation to help reach a decision about whether you do or don't need surgery, or whether the risks and benefits are less clear and nuanced.
And I guess this question is for both of you, so maybe Dr. Newberry, you can answer first. But how do you guide families in the decision between surgery and observation? And I guess we're basically talking about right coronaries now.
So for children with right coronaries, this is the most challenging part of the journey. And we're here really to guide patients and families in the decision making. You'll also find that different hospitals may give some different advice. Some recommend surgery for everyone, some prefer to watch and wait, and it can be confusing for families. Our own philosophy is centered on shared decision making, and we try to focus on primarily a child's safety, and then quality of life, mental well-being, and the ability to do things that you love. Sometimes the path is just clear. If a test shows a definite lack of oxygen to the heart during exercise, we always recommend surgery. And if the tests show there's almost no deprivation of oxygen, we often recommend observation. If the path is in the gray zone and the test results aren't clear, we have a detailed discussion with you, and we consider the artery's exact anatomy, whether your child is a competitive athlete, and most importantly, your family's preferences and values. And then finally, we follow patients because decisions can change. Kids change. So a child who loves video games at 12 might decide to become a varsity soccer player at 16. And that's the wonderful thing about children as they grow and change. And our medical plan has to adapt along with them. Finally, they might develop a symptom that they didn't have earlier. I'm going to ask Dr. Quinones to add to that.
Yes, the decision making is complex, and we don't pretend to have the answers all of the time. But there are, the way I think about it, the factors that I consider when thinking about a patient with an anomalous right coronary is number one, the anatomy. What does the coronary look like? And that's why we have the CT scan. You know, some are tighter. You know, the when they run in the wall, they look a little bit tighter. They look a bit more oval as opposed to round. We consider how much supply that coronary is providing the heart. We call that dominance. And some coronaries provide, right coronaries provide blood flow to the back of the heart. Others don't. And we look how long that intramural course is, right? How some of them are longer than others. But that's only one factor. And then we talked about the physiology, as Dr. Newberger said, can we prove that there's limitation of flow? Um, it Symptoms is one thing that's important, of course, but a lot of our patients, as Dr. Newberger alluded to, don't present just because they found this and may not have symptoms referable to the heart. So then it becomes an issue of how much a competitive athlete the patient become has aspirations to be. Issues regarding quality of life, which are important. How much anxiety the diagnosis is creating because of this risk of sudden death, however small it might be. Different families, as Dr. Newberger said, have different value sets and perceptions of what that might be. So this all comes down to a conversation that Dr. Newberger has, that I have, trying to weigh the risks and benefits of either observation or surgery, because each of them has its own risks and each of them has its own benefits. And with the family, it's that conversation of going through what are the small risks that may be with just observation. What are the small risks with surgery? We'll talk about surgery a little bit later, but this is what we're trying to balance along with families and their values and what's important to them.
Thank you. And yes, we're going to talk about the details of surgery later, but if a child is not going down the path to surgery with an anomalous right, how do you care for that child who is going to be observed? How will that child be managed? Maybe Dr. Newberger, do you want to take that one?
Sure. So observation management means that we continue to see your child for regular follow-up visits, and how often we see them depends on their anatomy. In other words, what's the architecture of the coronary, but also their activity level and their age. We do not restrict children with lower risk right anomalous coronaries from sports, even the most competitive sports. But we do have two important safety recommendations, and these are endorsed by national guidelines. First, we recommend that an automated external defibrillator, or an AED, is available on the field or court during practices and games. We also, I have a preference for sports where your child is always visible. for example, basketball or soccer, rather than when they might be alone and out of sight, like cross-country running.
Thank you. Okay, well, I know, decision making is really, really complex for these patients. And we have a coronary artery program. And can you just describe a little bit how the coronary artery team works at Boston Children's?
Sure. So making these decisions can be really stressful and difficult for families and also for medical caregivers. And that's why we want the best wisdom from the best experts. So we take a team approach. Each child's case is discussed at a multidisciplinary conference that includes our entire coronary artery team. And that includes pediatric cardiologists who specialize in these types of anomalies, experts in advanced imaging of the heart and the coronaries, adult cardiologists who have deep experience in the types of heart disease that deprive the heart of oxygen, and sports medicine doctors, and then our world-class surgeons led by Dr. Quinones. I'm going to ask Dr. Quinones for comments about how the team works.
So we have a meeting, a standing meeting that happens twice a month, and depending on the case volume, sometimes we add a third meeting every month. And patients come to us from their doctors. They reach out to us individually. There are many ways that the patients reach out to us, or the doctors reach out to us. But what we do is Annette, who's one of our MPs, and Ruth Miles, who can join us, who's also one of our MPs with the coronary artery program. They reach out to the families, get some information. We get records, and then we review them at this case conference. And we review everything, the history, the imaging, and we come up with recommendations for further testing, for additional imaging. But along that course, either before the meeting or after the meeting, we meet with the patients. If Dr. Newberger is the cardiologist, she'll meet with them. They meet with me, and we spend. I mean, I spend somewhere around 45 minutes to an hour talking about everything. It's something that requires a commitment to the families to speak with them, to describe all the uncertainties, what we know, what we don't know, and explain to them why we have testing that we would recommend. And then decisions don't need to be made. Fortunately, the treatment, certainly surgical, is not an emergency, and families have time to digest and think about what we've discussed, and come back to us with any further questions or decisions about how they would want to proceed. I must mention one thing, though, that's important is we invite, when cardiologists refer us patients from anywhere, we invite them. So they're able to join and present their own patient and listen to our discussion. So I think that's an important thing. I think it's a great group we have.
Thank you. And I think we're going to hop now into kind of our second group of questions, which is really going to focus on your expertise in surgery. And if you could tell us a little bit about how you surgically, or how we surgically approach and treat anomalous coronaries.
So the way the surgery is done is through an incision in the middle of the chest. We divide the breastbone, and we connect the heart to the heart-lung machine, and then we stop the heart. And we make an assessment in the operating room based on what we see in the coronary as to the best repair that should be done for that individual patient, for that individual particular anatomy. We have some options. We can reimplant, which is where we unplug the coronary artery and put it in the correct position. There was a question in the chat about, how is the sinus involved? It's because the origin of the coronary is coming from the wrong sinus. And what we want to do is provide unobstructed blood flow from the correct sinus. So the coronary is no longer intramural. And that can be done by reimplantation. It can also be done by something called an unroofing, where the coronary runs in the wall of the aorta, you cut the inner part of that wall. So when it's no longer intramural or running in the wall, it usually is coming out the correct sinus, if you will, sinus of Valsalva. What we've done here for a few years now is we have done something called an aortocoronary window. And really what that is we, rather than unplugging the artery and plugging it back in, if you will, which is the reimplantation, we leave it attached. And then we create a new connection in the correct sinus of Valsalva between the coronary and the aorta. And that new connection is now where the principal blood flow is going out to the coronary in an unobstructed way. The final decision is an intraoperative decision as to what is the best situation for a patient. The things that we watch out for or worry about in the operating room is getting a perfect result, such that there's no problems, that there will be lack of blood flow to the heart. And we want to make sure that the aortic valve, which is the valve immediately below the coronaries, is not disturbed in any way. And one of the advantages of the aortocoronary window and the reimplantation is that it does not perturb the aortic valve at all. But once we're done with the operation, we come off the heart-lung machine and we assess the heart. And we see how the heart is contracting. We see how the vessels on the surface of the heart. We do an echo. And once we're happy, we close the chest and the patients go to the intensive care. So.
And if you can just go over a little bit about what the hospitalization is like, what's recovery and so on after the surgical process.
Yeah, it's usually a day or two in the intensive care unit. We keep patients asleep overnight, mostly because we want to control their blood pressure around the time of surgery. These coronaries are very thin and friable. They measure about less than 2 millimeters in most instances, so we want to make sure that they're well protected. We actually, during that time, we actually have a special protocol in the intensive care unit to try to detect any problems with the coronary, to give us an early warning. And if we have any concerns, we would act upon those. The next day, patients have their breathing tube removed, and once we're happy with everything, then they go to the intensive care unit. They go to the ward out of the intensive care unit. Most patients stay in the hospital about a week. It could be less. Now, before they go home, we want to make sure that we're happy with the coronary. So every patient gets an echo. And for the anomalous right coronaries, if they see on the echo, if they see the coronary well, and they've had a really smooth course, then they're discharged home. Now, for anomalous left coronaries, we always do a CT scan because they can be more tricky to see. But if there's any question along the way, we will get a CT scan or even a cardiac catheterization. And it's not that the echo can't see the coronary or there's a problem with the coronary when the echo is done. It's usually that they just can't get the right images because of the postoperative state. But we want to make sure that before patients go home that we're satisfied with the coronary repair.
And a lot of patients, their biggest question is, when can I go back to school? When can I go back to sports? Both of you can weigh in on that. And I know it makes a difference between whether it's been a left or a right and what the circumstances are that brought them in. But maybe you could just point a little bit to those questions.
I guess I can start. Or do you want to start?
No, please go ahead, Jen. Thanks.
So after a child goes home, uh, we will see them in the hospital, or their cardiologist at home who referred them in. We'll see them in clinic about 1 to 2 weeks later. And at that time, we just check the incision, the surgical site, and an EKG, chest x-ray. And then they come back, if they're feeling well, they come back at about 6 weeks after surgery. We get an echocardiogram, and often we will do a stress test as well. At that point, if they are really doing well, we let them go back to usual activities. But hard sports where you might be stressing the breastbone, and I'll let Dr. Quinones speak more about that, we wait till they're closer to 3 months, sometimes a little leeway, and we always get a CT scan if they have not had one before they left the hospital. We always get a CT scan before we send children back to full competitive sports, just to be sure that everything is as beautiful as we expect it to be. We also keep children on aspirin, and we then, if all is well, we see them again about a year later. And often at that time, so this is now a year and 6 weeks or 3 months later, we often repeat one more CT scan to be sure that the healing of the coronary has not resulted in, and so far so good, but just to be sure that everything looks perfect. And then we follow them sometimes really for life, but much, much less frequently after that. Paying attention, we want everybody to be heart healthy with low cholesterol, low blood pressure. We love kids to exercise and to avoid getting very overweight. And I will see what Dr. Quinones can add to that.
Yeah, so there are a few things just from this recovery of the surgery. What's once the heart's repaired, as far as the heart is concerned, they're fine. But we do have to wait for the healing of the bone. So there is some of the restriction to going back to sporting activities is related to just allowing the bone to heal. And depending on the sport that the patient plays or participates in, that may be a little bit longer, a little bit shorter. Particularly contact sports, we may wait a little bit longer. But regardless, before returning to sports, as Dr. Newberg had mentioned, we want to make sure that we have a negative stress test and a CT scan that shows an adequate repair. And that's sort of at the 2 to 3 months mark, which actually coincides with the healing of the bone. So that's all times, that's intentional.
I realized there was one thing that we skipped over that I think maybe you want to talk about. I know that for right anomalous coronaries that require repair, you've been using a new technique called the coronary window to minimize risks of damage to the aortic valve. Did you want to speak about that a little bit?
Yeah, it's again, it's the way this came about is because of the notion that there may be a leakage of the aortic valve with the unroofing and because of some of the distortion that may occur with the aortic valve. So folks in the field have moved towards either reimplantation and us here specifically for this window, creating a new opening in the correct sinus so that blood goes out to the heart unobstructed. We've had very good success with that technique. I'm happy to say that we have not seen any problems. They stay open. They look very nice after the CT scan. So we're very satisfied with our results, and we're putting that together for publication. So it's something that's particular to Boston Children's. A lot of patients ask me, "Well, what is this window business? I've never heard of it before." But really, you can think of it as a variant of a reimplantation, but where you actually leave the coronary attached. So if we chat as a patient and a surgeon, I would go through those details with you. So.
And then does treatment vary in terms of children versus an adult? Is there an optimal age that you like to do surgery at? And I know that that may differ for left versus right.
Yeah, so in terms of age, for anomalous rights, we begin to consider surgery as early as 8, but we prefer to hold off on surgery until they're 10 or older. Now, that really depends. If you have a patient who's asymptomatic or a patient who we're worried about for whatever reason or has had an episode of sudden death, we will do it at any age because the patient needs it at that age. But in patients who are either asymptomatic uh, but require surgery still for one reason or another, I prefer for them to be 10 years or older for anomalous rights. For anomalous lefts, we lower the threshold a little bit. And Jane can comment that has to do with reported episodes of sudden death in that population. And it's a much more important and significant lesion. So,
Dr. Newberger, do you want to say anything about age?
Well, just as Dr. Quinones said, if somebody has ischemia and symptoms, we will operate at almost any age, and we can. But for a child who doesn't have symptoms and isn't at this enormously high risk, especially with right coronaries where the risk is so low, uh, it is, we basically prefer to wait till 10 and older. And that's the age cutoff also in uh, the surgical consensus guidelines. We have operated as young as age 1 year for anomalous right in a child who had important symptoms. That was very unusual. I would say for the lefts, if they have no symptoms, as young as 5, but more often 7 or 8. And this is because sudden events are so incredibly rare in very young children. So the risk that they have is so much less. A young child is not going to push himself or herself to kind of perform for peers. If it hurts, they stop. Whereas an older child doesn't want to let teammates down, might be much more competitive, and they have way more adrenaline in competition. That might explain in part the difference. And then finally, although your risk, even in adulthood, is higher than somebody that doesn't have anomalies, perhaps because people aren't in competitive sports as much after age 35, in older people, we are more likely to observe with an anomalous right, and sometimes even with a left if they're very old.
And I guess one more question, and then we'll go to questions from the audience. But I guess Dr. Newberger, for patients who are not going forward with surgery, do you see them very frequently during their adolescent years? Or I don't think we really touched on kind of the frequency and testing that we do in those patients.
Well, I would say it depends a lot on the anatomy of the patient. If it's a very low risk lesion, then no, we wouldn't see them often. If it's one of these gray zone issues and the child is an avid athlete who's, on the travel team and hoping to really get to varsity sports, I might see them as often as one every year for something like a stress echo, just to be 100% sure. And for the child who's doing ceramics and acting, much less frequently.
Okay, well, thank you. I think it's about 4:33, and we want to leave a little bit of time for questions. Are there anything else that either of you would like to say that we haven't covered? Dr. Quinones?
yeah,
Dr.
so
Newberger?
I think, we of course are talking about anomalous origin of coronaries, and these coronaries surgically they get manipulated. But we also think it's important to talk about overall coronary health. That's how I see it. And Dr. Newberger also already mentioned that about following patients and educating families and patients about the importance of not smoking, the importance of a healthy diet, the importance of being active, the importance of if when in the right age range, if there's high blood pressure or high cholesterol, to control those things. And we have conversations about patients with patients about these things, but because it's not just about the surgical repair, it's about their coronary health and their overall health. Because in the end, what we're really trying to achieve is to let kids do and patients do what they want to do in an unrestricted way, in a safe way. And that's really, it's not just about repairing their corner, it's about getting them back to whatever they want to do
Yeah.
in that way. So that's really our objective.
And I'm just going to make a quick mention because some of the questions that are coming in are about different coronary conditions, such as those that occur from other illnesses like Kawasaki disease. We also do deal with those other conditions in the coronary program, but because we had to kind of narrow the topic for today, we're just talking about coronary anomalies. So there are a couple of questions. Dr. Newberger, one question came in that says, is this genetic at all? If my child has this condition, what do you recommend for siblings and their parents? Should they also get an echo?
It's a great question. And the answer is that siblings and parents as well are at higher risk of having an anomaly if their child does. So we do recommend, as do many centers, that if you have a child with a coronary anomaly, either right or left, that brothers and sisters also have screening echoes. And then for parents, we recommend the parents speak to their own physician, but we do have a number of parent-child combinations. Just to be clear, for most children, no other family members have it, but relative to the general population, family members are more likely to have a coronary anomaly than, let's say, their neighbor.
Thank you. And then there's another question here that says, for a child who already had surgical repair on an anomalous right using an unroofing method at 5, at what age, but we can ask this in general also, at what age can a child like this perform a stress test? And at what age do you recommend that this be done? And this is particularly an active child. We can't answer individual questions, but just in general, I think the ability of different types of stress tests very much do depend on the age of the child. So maybe Dr. Newberger, you can expand on that.
We can do a stress test at any age, but the easiest stress test to do on a child, which is an exercise stress test, you really can't do reliably till often 7 or 8. Some very young children, like 6, can reach the handlebars, but depends on how tall they are. For young children in whom we are worried about a coronary, we do a dobutamine stress MRI, where they go to sleep, we give them medicine that simulates exercise, and we watch how the heart moves. So there's no age at which we cannot do a stress test, and we can also always do a catheterization. But after surgery, if a child was fixed at 5 years in general, and their coronary looks beautiful by imaging, you can usually wait till they're 7 or 8 and put them on a treadmill, or at least that's probably what I would do.
Okay, and thank you. And then this can be for either of you. If you don't see aortic valve leakage or regurgitation initially, is this something that can develop over time?
I think this is where the long-term follow-up is important. If one of the posts of the aortic valve has been manipulated in any way, the unroofing, it can happen. I think as part of the routine follow-up for the coronary, I think the aortic valve can be followed up because this is unlikely to be an acute problem, but it can possibly be a problem that develops over time, and it can be years. So, and it would be exactly the same kind of follow-up. It would be something that would be simple to detect with an echo that patients would get anyway, and it would be part of the checks that are done. So it doesn't add additional follow-up, but it is something that doctors who are following these patients know to check.
I would just add to that um, it's been very unusual. I can't think of somebody in at least the near-term experience who didn't have more than at least a solid mild amount of leakiness very early to go on to develop a dangerously great amount of aortic regurgitation. So I think if there were a problem many years later, it would be very slow, not a dangerous kind of situation. We fortunately have not seen a lot of that out of the early postoperative period. Would you agree with that, Luis?
Yeah, I definitely agree with that. Yeah.
Yeah. And it is one of the reasons that we do periodic echo screening surveillance, and we don't do, and that's the best way for us to see that afterwards. Let's see, Dr. Quinones, I think one of your patients here wrote, first of all, thank you. You performed unifocalization on their
Yeah.
daughter. And they had questions about, uh, do you feel that there's any limitations beyond age and size, I guess, kind of specifically, such as technology that make a repair harder at one point or another? And what do you wish you had more of or better technology for? I don't know. So that's a bit broad, but anyway, there you
Yeah.
go.
So from a surgical point of view, um, I think uh, I don't think that the focus on technological development would be on the surgical side. Really, the biggest challenge I think the field, not only us, but the field faces is to come up with the perfect test to tell us which patients is it okay to observe and which patients we should operate on. When we do all these tests to test for blood flow, these stress tests, which can be stress with an MRI, an echo, a PET scan, a cardiac catheterization. Those tests are really helpful if they're positive, because then everybody agrees there's limitation of blood flow, and we should do something about it. They're helpful if they're negative, but they cannot really tell us for sure if that sort of takes away the risk. Um, and if we could develop a test that gave us that answer, then that would be groundbreaking in the field. So I don't know, Jane. I don't know what you think of that. So
Yeah, I think that's really um, wise.
I think it's also a challenge because some of these tests that really assess coronary flow are best done at adult hospitals. And so we have a very close partnership with one of the adult hospitals, Brigham, right near us. And we can have children have certain tests that at their facility, so we can go back and forth, and that's been very helpful. I don't know if you want to say anything about that, but that is a
no,
challenge.
it's true. Not all hospitals will have all the technology. Not every hospital has every single test that they can do. So, and some of them get really good at whatever test they're able to do in their own hospital. But yeah,
Yeah.
it's nice to be able to have the options for us because we can pick the test based on the patient and based on the particular circumstance. So
And I guess just in the interest of time, maybe one more question. One of the parents asked, is there a particular age at which we tend to see patients having more symptoms? Is it adolescence, late childhood, young adult? Have we been seeing? So maybe Dr. Newberger?
At what age do they start showing symptoms?
Yes,
So
question.
I would say the nature of symptoms is very different according to age. The younger you are, the harder it is to interpret. So a 5-year-old often has a lot of trouble expressing what they feel in their chest. And sometimes we're not sure if it's a coronary or maybe they are having a little rhythm problem, which are very common, like fluttering from a completely unrelated problem, or they have indigestion. In terms of typical, much more typical angina, where you have that squeezing pressure feeling in your chest from not enough oxygen, most of the time those children are older. I would say older than 10 most often. And interpreting symptoms is incredibly hard in young kids. At what age could you actually have insufficient oxygen to the heart muscle? It could be at a much younger age. You'd have to take your time to try to sort out whether the symptom reflects a real problem with not enough oxygen or a very different problem. And as I said, it's complicated, but you can get, I think, to the right answer.
Thank
Luis,
you.
any additional
Luis?
thoughts about that?
no, it's a huge challenge, right? It's a huge challenge. And I talk to patients about attribution. Can you attribute the symptoms that they're having to the coronary? Can you draw a straight line? And that's very difficult to do most of the time. Most of the time. And we have this conversation about, well, these symptoms, whatever they may be, brought you to attention. But we will do, if we operate and we get a perfect result, they may still have symptoms, but at least we know it's not the coronary. But most of our patients are very thankful, and the majority, my experience has been that their symptoms go away. So,
We have some additional questions, but they're really about other coronary anomalies and then also about Kawasaki disease. So I think,
Um,
Jane, did you want to say something? Sorry,
yeah,
go ahead.
I do think it might be worth Dr. Quinones answering the question about coronary osteoatresia.
Okay, perfect. So there is a question saying, can you comment, maybe just a quick explanation of what coronary osteoatresia is and how we evaluate that types of repair. So I don't know if you have a few minutes to go through that.
no, of course. So coronary osteoatresia is basically describes where the coronary either doesn't attach to the aorta, or it's narrow to the point that there's no blood flow. And one can think, well, how can a child even be, present this way? How is this even possible? But children have an incredible ability to adapt, and the other coronary, on the right or the left, the one that is not atretic, can provide the blood flow, but up to a point. Eventually, these patients do present in some form or another. And there are a couple of options, but the option that most surgeons and we prefer is to recreate that connection in some way. So recreate the connection between the coronary and the aorta. We try to avoid doing a bypass. We want to create the most natural blood flow through the coronary, and that can be either and in most cases, I should say, is either cutting across the area that's narrowed or atretic and adding a patch there. And we can do that in almost all cases. For different kinds of reasons, sometimes that's not possible, and we have to do coronary artery bypass, even in kids, to be able to deal with this problem. So that's what I would say about atresia. Hopefully that answers that.
No, that was great. Thank you. Also, there was a question that just came in about, I guess, the long-term outcomes and what are the unanswered questions when you compare outcomes from roofing versus reimplantation, adding in your windows versus bypass in pediatric patients. So that's maybe both of you can weigh in on that one. It's a great question.
It's a really important question, and families ask me this all the time. And this is one of there's still a lot to learn about anomalous coronaries and what we do for them. From a surgical point of view, um, let me step back a moment. Our time horizon for a successful surgery is 60, 70 years, right? And what happens to those repairs over this period of time, even 20, 30 years, that information for us does not exist. And what I tell patients, well, we don't see patients coming back in droves, so that's a good sign. But we're committed, the whole part of this coronary artery program, uh, we're committed to following these patients and see what happens to them, because that's really important. And we participate in a multi-center data collection effort by the Congenital Heart Surgeon Society. We participate and provide data for our patients so they can also follow these patients as well. And one of the difficulties is that going back to the risk of sudden death, it's so low. It's really hard to, if that's your marker of success, it's really hard to get enough patients to be able to say that this repair is better than that repair. So this is why, at least early on, we in addition to follow patients clinically, test them, do CT scans and imaging, and do stress testing. Because if the coronary is open, even after a year, and the stress test is negative, I feel personally that there's a good chance that it's going to stay that way. But we still want to know, and we still want to follow you. So, Jane,
Yeah, but not too often.
not too often. No, no, no,
I
no.
have to say, we have a ton of reassuring data. Um, And I would just add to that that a bypass operation is something that we rarely would do for a coronary anomaly. We might do it for Kawasaki disease. That's very separate. I see there's a question of that, but it's not generally necessary to do a bypass with coronary anomalies. And we know that in young children, bypasses can be great and they can grow with the child, but you only have two internal mammary arteries that we use for bypass. And we can always use those if we do an unroofing and maybe when somebody's 50 or 60 need to do a bypass. Can't do it the other way around.
Yeah. No, we want to recreate the natural blood flow to the coronary out of the aorta, number one. And as Dr. Newberger says, we want to keep those options for the future. And it may not be anything related to the anomalous coronary. Atherosclerotic heart disease, hardening of the arteries. Patients may develop that in the future. You want to preserve the bypasses for the adult surgeons to be able to do bypasses as necessary, which may have nothing to do with the anomalous coronary. So we're not only thinking in the short term, we're trying to think in the long term. Again, going back to the principle of coronary health.
Yeah. I think that is most of our questions, and we so appreciate all of you taking your time out this afternoon. And this will be available also up on the web. And also, I think that they're going to put up a slide as to how to contact our coronary program if you have any additional questions or if you want input on a specific case.
The question about the sudden risk of sudden death instead of just doing surgery for anomalous coronaries, I think that's probably the question that makes patients and families really anxious. I think going back, the absolute risk of sudden death is very low, and the risk of surgery is very low. At least here, we haven't had a death from an elective anomalous right. Doesn't mean it can't happen, but it at least tells us that the risk is really, really low. And it's balancing those two risks that we try to help families.
Yeah. I would say that the concern and the fear that people feel is the worst part of this, especially with rights, because the risk is so low. And if you could wave a magic wand and fix it and never think about it again, everybody would just do surgery. But you have to balance the risks and benefits of both. And that's really the art of medicine in many ways. I would just end by saying we're all here. Dr. Quinones is here. I'm here. We have, each of us have a team of people. So there are many people in the coronary team. Annette Baker and Ruth Miles are also here for questions. Just reach out to us, as you can see on this last slide. We're happy to answer questions.
Absolutely, yes.
Thank you again so much.
Thank you.